Hi, my name is Kamran Jiwani, and for this presentation, I will be talking about a classification-based model for septic shock prediction. Sepsis and septic shock-related deaths are amongst the leading cause of death in US. This results in tragic loss of countless lives, and it also costs the economy about $15 billion annually. This area really resonated with me, and so for my final project, I decided to come up with a way to predict the onset of sepsis. Before I go deep dive into the work that I did, I just wanted to point out that there are some works that have been done in this area. One of the models that is used is the MUSE approach, which is the Modified Early Warning Score System, which predicts the onset of septic shock with an AUC of 0.73. Another time variable regression model called TRUES is a score-based approach, and it is shown to predict septic shock 28 hours before its onset with an AUC of 0.83, which is pretty high. The TRUES score system came up with these results using the MIMIC-2 electronic healthcare data as its primary source of data. My paper is an extension of TRUES paper. However, instead of time-varying regression-based model, I am using a classification-based approach to predict sepsis 24 hours before its onset. For this project, I'm mainly using Spark and mLib libraries, and for minor data cleanup, I'm using PostgreSQL. Once the data is loaded into Spark, using Spark, I identify my cohorts. My initial cohort was basically those individuals who were diagnosed with sepsis. I looked for texts such as sepsis in my diagnosis tables. My control was anyone who was alive at the time of discharge and did not have sepsis. However, this approach was not sufficient. I realized that diagnosis date was not present in the diagnosis cases that I'd identified. And so I ended up going through other tables to find this information. Also, since I am only looking at 21 features, not all of the patients had those 21 features tested for. Therefore, after taking into account all of these factors, my cohort numbers reduced from 46,000 to 14,000, with 2,000 case patients and roughly 12,000 control patients. So here's my overall design. I first load data using Spark. The data is coming from the Mimic3 database. In some cases, I had to clean up the data before I can load it using Postgres. Next, I identify my cohorts, which I have already talked about in the previous section. Once the cohorts are identified, I do feature creation process to select 21 features that can be used to identify patients who may go into the sepsis state. Some of these features include heart rate, systolic blood pressure, and other lab measurements. Finally, using these features, I pass them through two different models, the support vector machine model and the logistic regression model, to produce my results. So here are my results. The graph on the left is the ROC after using support vector machine. The graph on the right is the ROC after using logistic regression. Since the data is so skewed, 2,000 cases and 12,000 controls, the accuracy, precision, recall, F measures were not very good metrics for analysis. And so for comparison purposes, I plotted the ROC curves and I used the AUC as my primary metric. Overall, I think I did pretty good. I ended up using 21 features compared to the 52 features in TRUES paper, and I was able to predict with an AUC of 0.81 using logistic regression learner. The original TRUES paper had the AUC of 0.83. In conclusion, I think it was really good to see that a simple classification-based model that I came up with in about 4 weeks or less can be converted into an approach to solve a complicated early sepsis diagnosis problem with reasonable success. And this was the main highlight for me all throughout this project. Though my results were fairly good, there are considerable areas of improvement for my model. For example, I experimented by increasing the prediction window to from 24 hours to 30 hours, 40 hours, but I did not try reducing it. I think reducing the numbers may give me better results. Unfortunately, there was no clear way for me to identify some of the essential features for sepsis diagnosis, such as SOFA and FiO2 and urine output in the last 6 hours. This is something that I'm hoping that I can identify eventually, and I believe that that will help me improve my results. I can also look into other ensemble algorithms and lazy algorithms such as KNN. I think that may be another area to look at to see if I can improve the results. Two observations that I had were: number one, it can be really difficult to navigate through complex medical data. A lot of the useful information reside in free text notes, and perhaps an approach may be needed to first harness that information, store it in a database, and then use it more efficiently. Big data tools such as MLIB still have a lot of room for improvement. For example, though I could see and generate ROC score for my model, the curve features were not present, and I had to actually manually generate my curves. This is all I have. Hope you like the presentation. Feel free to give me your feedback. Thank you.